So g'day, I'm Dr. Paul Mason, and today I'm going to challenge everything you think you know about this disease, atherosclerosis. You've been told that high LDL levels coat the insides of blood vessels in much the same way that a drain gets blocked by fat. And that's just absurd. Higher LDL cholesterol levels, in fact, are associated with longevity. The overwhelming finding of this systematic review of 19 cohort studies with more than 68,000 participants was that the higher the LDL cholesterol level, the lower the chance of death. Let's take a look at exactly what LDL is. A complex molecule comprised of both lipids and proteins that your body devotes a lot of resources to produce. In pink here, you can see pure cholesterol itself. It's carried as a cargo internally, as indicated by the yellow arrow, and it's also dotted throughout the outer membrane. And you can see that cholesterol is only one component of many within an LDL particle. The fact is, though, LDL particles can and are found in atherosclerotic plaques. So does that mean it causes atherosclerosis? No. Just because two factors coexist does not imply that one caused the other. The fact is, as shown by this paper, 75% of patients hospitalised for heart attack do not have high LDL levels. Rather, we have compelling evidence that the root cause of heart disease is actually this: a blood clot, or more specifically, thrombosis. Essentially, atherosclerosis is the result of blood clots forming inside blood vessels. To begin with, red blood cells contain a chemical unique to them called glycophorin A. This chemical is not found in any other tissue in the human body. And yet, scientists have been able to prove the presence of glycophorin A, and by extension red blood cells, deep inside atherosclerotic plaques by using a special brown stain. Of course, blood clots are not just made of blood cells. They also contain platelets and fibrin, which forms fibrous strands binding the clot together. And both these too have been found buried deep inside atherosclerotic plaques. The lipid hypothesis model of heart disease cannot explain this at all. Now, one interesting thing about these clots is that they can occur episodically over time, one on top of another, which leads to the prediction that atherosclerotic plaques would form in layers. And indeed, this is exactly what we find. Here's an example of a single layer plaque containing a lipid-rich core covered by a fibrous tissue connective cap. And here is an example of a plaque with two distinct layers, separate fibrous caps being clearly visible. Hang on, you might say. What about the cholesterol-like crystals that we see in plaques? Where do they come from? Well, it doesn't come from LDL. So first of all, understand that the LDL in atherosclerosis is contained within foam cells. These foam cells are formed when macrophages ingest damaged LDL particles. And once ingested, the LDL particle is broken down, releasing the cholesterol contained within it. The cholesterol is then bound to fatty acids, resulting in it being stored in a droplet form. And they will remain in a droplet form even if they get released. Not a crystal, a droplet. That is, the cholesterol found in foam cells cannot lead to the crystalline deposits seen in atherosclerosis. Rather, the cholesterol found in atherosclerosis comes from red blood cells. You see, their outer membrane contains more cholesterol than any other cell in the body. And this paper not only describes the central accumulation of red blood cell membranes within atherosclerotic plaques, It also details how by injecting red blood cells into animals, investigators were able to produce atherosclerotic plaques that contain both cholesterol crystals and LDL-laden foam cells. So thrombi, or clots, can elegantly explain the constituents of atherosclerotic plaques, all of them. So I'd like to now take a closer look at the so-called cholesterol crystals themselves. So understand, on this slide here, you're not looking at crystals directly. You're looking at the spaces where they used to be before they were dissolved in processing. That means that another component could form the crystals. So anything with a near identical structure would lead to the exact same appearance. Enter phytosterols, plant versions of cholesterol, and these are almost identical to cholesterol. And these too form crystals, crystals which are difficult to differentiate from cholesterol crystals. And phytosterols can be easily delivered by red blood cells, given that they can actually be incorporated into the membrane of red blood cells themselves, in the same way that cholesterol is carried in the red blood cell membrane. And while the foam cells don't release cholesterol in a crystal form, as we've discussed, foam cells are only too happy to expel the phytosterols when they can. At this stage, it's probably not going to surprise you that phytosterols too are readily detected in atherosclerotic plaques. This is a case report of a 33-year-old male with premature, severe atherosclerosis. And predictably, when researchers performed a biopsy of his aorta, they found plant sterols. Fortunately for most of us, our bodies reject most of the plant sterols that we consume, with only about 1% being absorbed and assimilated into our tissues. Some people, however, are unlucky enough to absorb much larger amounts of these plant sterols, between 15 and 60%. And this condition is called cytosterolemia, and the consequences can be dire. There being one case of a 5-year-old dying from sudden cardiac death. Despite this, these phytosterols are often lauded for their ability to reduce cholesterol levels, which is why products such as this, containing plant sterols, are actually promoted, perversely promoted for cardiovascular health, despite there being approximately zero evidence of cardiovascular benefit and significant evidence of harm. And this, I believe, is where seed and vegetable oils need to come into the conversation, both of which contain significant amounts of plant sterols, even olive oil. And it's the plant sterol content of these oils which underpins their cholesterol-lowering effects. With this in mind, can you predict what the effect of each of these oils would be on LDL levels? Now, while olive oil and coconut oil are not generally considered seed oils because they're made from flesh, they still contain phytosterols. So this study looked at the impact of these three fats and found that both coconut and olive oil resulted in a drop in LDL levels, in my opinion, likely due to their phytosterol content. And this despite the coconut oil being used in the study being 94% saturated fat, a clear repudiation of the claim that saturated fat increases LDL. Now, one of the major reasons seed oils contribute to atherosclerosis is that their polyunsaturated chemical structure contains unstable bonds which are prone to oxidation. Basically, all the seed and vegetable oils you see in stores are oxidized. Fish oil too. This study found that oxidation of walnut oil occurs within days of it being produced. And when oxidized oil is consumed, oxidation products are absorbed and enter the body. The more oxidized the oil, the higher the level of blood oxidation products. The story for blood oxidation products becomes even more interesting in subjects with poor blood sugar. The two left columns here represent subjects with normal blood glucose levels, and the right column those with poorly controlled diabetes. You can see that the blood oxidation product level is much higher after consuming oxidized oil in the poorly controlled diabetics. Furthermore, the oxidation products persisted for 3 days in the diabetic subjects, while being cleared in 8 hours in the non-diabetic subjects. So what, you might ask, is the problem with oxidation products in the blood? The answer is atherosclerosis, as in oxidation stress in the blood causes clotting or thrombosis, which, as you now know, is the source of atherosclerotic plaques. In the words of this paper, oxidative stress is involved in all of the major processes involved in the development of thrombosis. So we're now starting to understand why atherosclerosis happens. So what is oxidation? It's basically an umbrella term that refers to a chemical reaction where an electron is ripped away from a molecule. And this is basically what rusting is. And because of this reactive tendency, oxidation products in the blood can activate clotting factors. Of course, seed oils are not the only source of blood oxidation products. Pollution is a major one. When we inhale pollutants, if they're small enough, they can pass through the blood vessels, coursing through and around our lungs, and enter our circulation. And this has been proven by research detecting pollutant particles within just 1 minute of inhalation. This is why smoking causes heart disease, as in the case of President Eisenhower, who was smoking 2 or 3 or more packs a day. Of course, some pollutants are worse than others. Remember leaded petrol, which used to fill the air with lead for us to inhale? Well, lead is a particularly potent contributor to oxidative stress. Lead atoms are just the right size to be inhaled and enter our circulation. And this study from 2018 concluded that 1 in 6 deaths, or 18% of the 2.3 million deaths occurring in the United States every year, was attributable to lead. A huge number. And remember, it all comes back to oxidation products in the blood. But just how exactly is oxidation carried around in the blood? What does it look like? How about an LDL particle? Hang on a second. Didn't you just tell us that LDL wasn't dangerous? Yeah, I did. That's true. People with higher LDL levels on average do live longer, but LDL particles can become oxidized when they react with other oxidized substances. You see, normally in the blood, there's a single healthy population of LDL in a normal distribution, as shown by a single peak here in yellow in the LDL section. This LDL won't harm you. The size and density, though, of LDL changes when it becomes damaged, of which oxidation is a major cause. In this sample, you can see 4 distinct populations of LDL, 3 more than normal, representing the presence of oxidized and damaged LDL. And this LDL is often referred to as small dents, given that as they oxidize, the LDL particles become microscopically smaller. And while most people who have heart attacks have normal total levels of LDL, there being no difference in the total LDL levels in those with and without heart attacks, when we look at oxidized LDL, it's a different story. Look at the level of damaged LDL in the age group on the left without heart disease compared with the 2 groups on the right with heart disease. Night and day. Oxidized LDL, of course, or any other blood oxidation product, is able to damage this furry layer which lines our blood vessels, called the glycocalyx. And the glycocalyx is perhaps the most important level of protection against atherosclerosis that most people, doctors included, have never heard of. Amongst other things, it shields the artery wall from coagulation particles, secretes antithrombin 3 that inhibits clots from forming, and stimulates the production of nitric oxide, itself another potent inhibitor of coagulation. The fact that oxidized LDL damages the glycocalyx significantly increases the risk of atherosclerosis. And oxidation stress too appears to be the cause of calcification within arteries. You see, oxidation has been shown to lead to DNA damage, which leads to the expression of a moiety called poly-ADP ribose. This then lays down calcium within the lining of arteries. That coronary artery calcification is associated with unstable plaques and heart attack is therefore probably not a coincidence. Interestingly, statins are also known to damage DNA, a fact apparent to the Japanese scientists who stopped researching the mycotoxin which eventually became the first statin because of the increased rate of cancer in dogs, which makes it unsurprising that statins also significantly increase coronary artery calcification. This ties in with the most common cause of sudden heart attacks, which is not the presence of atherosclerotic plaques themselves, but rather the plaques rupturing. High calcium scores indicate an increased tendency for atherosclerotic plaques to rupture. In the case of the rupture of an existing atherosclerotic plaque, the resulting thrombus that forms can be so large that it completely occludes the vessel, resulting in a heart attack. Atherosclerotic plaques themselves, though, while narrowing arteries, do not usually lead to complete occlusion. They restrict flow, but they don't completely obliterate it. This then affords the opportunity for something called angiogenesis, or the creation of new blood vessels. Essentially, when a blood vessel becomes too narrow to carry the desired volume of blood, new blood vessels can be created as a detour around the restriction. This is why coronary artery calcium scores are a much better predictor of cardiac death than vessel narrowing itself, because they reflect the stability of the plaque or its tendency to rupture and form an occlusive thrombus. This study, for example, found that once calcium scores exceed 100, representing the presence of unstable plaques, it doesn't matter whether or not blood vessels are narrowed. The risk of cardiac events or death remains the same. Essentially, if your calcium score is over 100, the data suggests that invasive angiograms, where dye is injected so the outline of blood vessels can be seen, is largely pointless. This is why stenting the blood vessels to open them up also doesn't improve survival in heart disease. So while it can partially open occluded blood vessels that can help with symptoms such as angina, stenting doesn't eliminate the risk of sudden blockage, which in fact is actually what kills people. This study, published in 2007, randomised 2,287 patients with heart disease to receive either stenting plus drugs or drugs alone. And stenting was shown to be of no benefit. More recently, this 2020 study randomised 5,179 patients with heart disease to either stenting plus drug management or drug management alone. And again, it found absolutely no mortality benefit to stenting. So what's going on inside a plaque to make it susceptible to rupture in the first place? Well, it depends mainly on the integrity of the fibrous cap of connective tissue, shown here by the yellow arrow. In this example, with a thick cap, this plaque is quite stable. Compare it to this plaque, which has a thin fibrous cap. This plaque is at high risk of rupturing. The question is, what causes the fibrous cap to thin out? And I believe the answer comes back to foam cells, the macrophages that have ingested the oxidized LDL. You see, after ingesting oxidized LDL, foam cells secrete enzymes that break down connective tissue. They break down the protective cap over the atherosclerotic plaques. These are called matrix metalloproteinases, and these enzymes have been independently associated with both the tendency of plaques to rupture and cardiac mortality. Matrix metalloproteinases are also involved in the action of statins. There's some evidence of mortality benefit in those who have already had heart disease to taking statins. It was assessed by this systematic review, based on 11 studies, to be 4.1 days. But still it was there. And the fact that statins inhibit the release of plaque destabilizing matrix metalloproteinases no doubt plays a role in this marginal effect, as does their inhibition of blood clotting. This is probably why their use is associated with a significantly increased risk of brain bleeding known as hemorrhagic stroke. It's noteworthy that the reduction in secondary events has nothing at all to do with the lowering of LDL. As an aside, the presence of oxidized LDL is quite reliably associated with something called the triglyceride to HDL ratio, there also being robust evidence that a low ratio is associated with a reduced risk of cardiovascular disease. And this is something that can easily be assessed using a standard blood lipid panel. There's another elephant in the room, of course, when it comes to heart disease, and that's diabetes, which is associated with a tripling of the risk of death from heart disease and stroke. That high levels of sugar in the blood are so problematic has been known for a long time. This research from 1962 demonstrated glucose abnormalities in 73% of heart attack patients. And again, the mechanism is oxidative stress. Both high and especially fluctuating blood glucose level generate oxidative stress at the level of the mitochondria, the consequences of which you saw earlier when combined with seed oil consumption, with oxidation products detectable in the blood for 3 days in diabetics. A very good reason to keep your blood glucose level in check. The corollary of all of this, that oxidation is a major cause of heart disease, is that antioxidant supplements may be beneficial. For example, the antioxidant N-acetylcysteine has been found to be protective against heart disease, as has the antioxidant coenzyme Q10. So I'd like to now circle back and finish off the discussion about seed oils. So I believe the evidence of harms from seed oils are convincing enough to discourage their consumption. So the consumption of seed oils began to rise in the early 1900s, well-timed to have a causal role in the heart disease epidemic. And it's not just this association that suggests their consumption is problematic. 4 randomised controlled trials, the gold standard of research, have demonstrated harms from consuming seed oils. In this study from 1965, patients post-heart attack were randomly allocated to one of 3 groups. There were 2 intervention groups consuming a daily supplement of either olive or corn oil, and a control group on a regular diet. And after 2 years, 75% of the subjects in the control group remained free of repeat heart attacks, compared to 57% and 52% of those in the olive and corn oil groups, respectively. Hardly a ringing endorsement for olive or corn oil, the conclusion of the investigators was quite blunt, being that corn oil cannot be recommended for the treatment of ischemic heart disease. And in my opinion, this study also raises questions about olive oil. Now, the Sydney Diet Heart Study was a randomised controlled trial examining the effect of replacing saturated fat with polyunsaturated fat in men who'd had heart attacks. But despite being finished in 1973, the results regarding whether the intervention reduced cardiac mortality were destined to never actually be published. And it was only after Dr. Chris Ramsden uncovered the raw study data on punch cards and magnetic tapes in a basement that the full results were finally published some 40 years later. The key finding being that the increased intake of polyunsaturated fats, as found in seed oils, increased the risk of death in these men by 62%. A similar story exists for the Minnesota coronary experiment, which also finished in 1973. Now, this was a double-blinded randomised controlled trial on more than 9,000 men and women, again evaluating the effect of increasing polyunsaturated fats while reducing saturated fat. And again, there was an inexplicable delay in publishing the full findings. It took 16 years to publish a somewhat redacted version of the study findings. And again, a very similar story. The mortality data from the Minnesota coronary experiment, which was completed in 1973, was not published until 2016. And when the results were finally published 43 years later, after the raw data was located by Dr. Chris Ramsden, that same chap again, it was revealed that increased seed oil intake increased the chance of death, a result that was knowingly hidden for decades. And when the now deceased lead author was asked about this delay, he explained it was because they found the results disappointing. Now, more recently, we have the Women's Health Initiative study, published first in 2006. It was a massive study of over 48,000 females, designed to be definitively assess the benefits of lowering saturated fat and increasing polyunsaturated fat intake. And the most important outcome clearly being that of survival. And while the results were technically published, they were done so in a very obscure, some would say suspicious manner, almost like the authors didn't want anyone to actually see them. This vague sentence on page 661 of the publication was the single reference to the only statistically significant finding of the whole paper. The finding being that females with a history of heart disease faced a 26% increased chance of complications like heart attacks, if they followed a low saturated fat diet. Furthermore, the most recent published data on the Women's Health Initiative demonstrates that this risk to the low-fat intervention group has only increased over time to between 47 and 61% increased risk. The last few years have seen various people debate as to whether seed oils or carbohydrates are worse for health. And I think the answer is both, although it does depend on the dose. Take, for example, this British Medical Journal paper which found that in terms of percent energy intake, diets exceeding 6% seed oils were more harmful than diets containing 50% or more carbohydrate. That is, high seed oil diets defined as constituting more than 6% of daily energy intake are associated with more mortality than high carb diets. Based on the fact that the average Australian derives 13% of their energy from seed oils, it would seem that seed oils are indeed more problematic on a population basis. Now, I'd like to acknowledge the work of Scottish GP, Dr. Malcolm Kendrick, on exposing the role of blood clots in atherosclerosis. He is the author of this book, which provides an excellent summary of the clotting theory, and is also the subject of cancellation by Wikipedia, accused and convicted by online editors of being a fringe figure with the audacity to argue against the lipid hypothesis. Outrageous. And in closing, I'd like to briefly present something for the first time publicly. My theory on the mechanisms of insulin resistance. How can it be caused both by sugar and seed oils? In actual fact, I believe the mechanism by which seed oils and sugar causes insulin resistance is near identical. And this also explains why statins make it worse, why the liver is more affected than fat, and numerous other things. Understand that insulin resistance is increasingly considered the root cause of chronic modern disease. This study divided study subjects into 3 groupings based on their level of insulin resistance and followed them for 6 years. In the subjects with the least insulin resistance, shown on the left, there were no recorded clinical events over the 6-year study period. Contrast this with the insulin-resistant subjects on the right, who from the top down developed cerebrovascular disease, type 2 diabetes, coronary heart disease, cancer, and hypertension. Equally striking is this research on insulin resistance and obesity. On the left, you can see that only 2% of the subjects with the least insulin resistance became obese over 8 years. Compare this with the 72% of the most insulin-resistant subjects, 36 times greater. So what exactly is insulin resistance? Well, it refers to a state where insulin does not work as it should. To compensate, the pancreas often secretes more insulin than usual, leading to high insulin levels, which is often synonymous with insulin resistance. Let's take a look at insulin resistance in action. So one of the functions of insulin is to remove glucose from the circulation and place it into muscle, liver, and fat. Under the action of insulin, muscle, liver, and fat tissue all receive glucose from the blood. Insulin resistance, however, means that the insulin is less effective, and notably, the liver is most affected, this results in the liver not receiving glucose as it normally would. Because muscle has a finite capacity for how much glucose it can store, under the influence of increased insulin levels, fat tissue now receives more glucose. Now, the key to understanding the cause of insulin resistance is to realise that it's not caused by a problem with insulin itself, but rather by the receptors upon which insulin acts. Which makes sense because the state of insulin resistance is usually associated with higher levels of insulin. So I wondered whether I could find any evidence of any mechanisms by which both excess sugar intake and seed oils could impair the functioning of the insulin receptor. Now, we've got an abundance of evidence linking fructose-containing sugar with insulin resistance. This includes several experimental studies. For example, this study demonstrated that simply by reducing fructose intake, insulin resistance was rapidly reversed. 41 children had their fructose intakes reduced from an average energy proportion of 12% to 4%, while maintaining their total level of energy consumption. And after just 9 days, there were large improvements in insulin resistance, not to mention a 47% reduction in liver fat after just 9 days. The reverse is also true. Increasing sugar consumption induces insulin resistance. In this study, 80 subjects were randomised to either more than 2 or more than 4 servings of fruit a day. And after 6 months, the group consuming the most fruit, along with all of that extra fructose, were significantly more insulin resistant, as well as obese. Now, to understand how sugar causes insulin resistance, we need to come back to the structure of a cell, which is surrounded by a membrane known as a phospholipid bilayer. And embedded within this phospholipid bilayer are insulin receptors, which span the thickness of the cell membrane. When insulin binds to the receptor is activated and passes its message into the cell, upon which the downstream actions of insulin take place. If this receptor doesn't work, you'll have a state of insulin resistance where insulin seems to not work properly. The missing link in understanding insulin resistance comes down to the fact that the phospholipid bilayer is in fact not a homogeneous ocean of phospholipids. Rather, it is punctuated by little islands recently discovered known as lipid rafts, which float within the cell membrane. These lipids are actually below the resolution of light microscopy and contain large amounts of cholesterol, 3 to 5 times that of the surrounding membrane. And insulin receptors are embedded within these lipid rafts. Anything that disrupts the lipid raft can disrupt the function of the insulin receptor. It's well established that excess dietary fructose results in the overproduction of a waxy lipid molecule called a ceramide. And ceramides not only disturb lipid raft function, but they've also been proven to lead to insulin resistance. What about seed oils, though? Well, this 1965 paper provides the earliest account I've found of seed oils causing insulin resistance. It describes the experience of 2 subjects who were ultimately removed from the study assessing corn oil supplementation. One subject developed glucose in the urine, a classic symptom of diabetes. The corn oil was then stopped, and the glucose disappeared from the urine. The corn oil was then resumed, at which point the glucose returned. Eventually, the investigators finally stopped the corn oil supplement for good. The other subject was also noted to have developed diabetes based on the glucose tolerance test only a few weeks after commencing the oil supplement. Now, recall that seed oils contain large amounts of these sterols, the fake plant cholesterol, and sterols have not only been proven to be effectively incorporated into cell membranes, but they've also been shown in some studies to disrupt lipid rafts. Remember too the high cholesterol content of the lipid raft. Well, depletion of lipid raft cholesterol has been proven to be detrimental to both lipid raft function as well as impairing insulin receptor activation. This is no doubt the reason why the rate of diabetes is significantly increased in people who take statins. And what about the differential impact of insulin resistance on different tissues? Well, as it turns out, there are differences in the lipid raft structure between liver cells and fat cells. And this, I believe, explains their differential sensitivity to cholesterol depletion, ceramides, and sterols. And all of the literature which I've looked at so far seems to support this notion. So I was sitting in this same theatre yesterday listening to Dr. Zoltan talk about how antipsychotic medication causes insulin resistance and diabetes. I thought, well, that was interesting. Let's have a look and see if there's any literature on the topic of lipid rafts and antipsychotic medication. And lo and behold, quick search later on Google Scholar, and there are papers describing how antipsychotic medication disrupts lipid rafts. So basically, everywhere I've looked at, the lipid raft seems to be central to the development of insulin resistance. And there are biologically plausible mechanisms supported by literature describing how both excess sugar intake and seed oil intake can contribute to lipid raft disruption. Thanks for listening.